some of this, I gave a lecture here about 2 years ago, ran rounds about perioperative medicine. This lecture will incorporate some of those, some of that information in some of the slides. I do think it's worthwhile to review this information, since reviewing can also just help embed some of the concepts that I'll be talking about. So what will we be talking about today? We're going to talk about preoperative risk assessment. How do you assess a patient's risk as they enter their planned surgery? What about individual diseases? How do we assess them, and how do we work them up, and how do we manage them preoperatively? We'll also talk about anticoagulation bridging preoperatively, who should be bridged, who does not be bridged. And I'll briefly discuss some of the guidelines, if we have time, that we've developed here at the Baptist. So a lot of this information is based on guidelines, and there's a paper from 2007 looking at guidelines at perioperative cardiovascular evaluation and care for non-cardiac surgery. So this was well summarized in this paper. Some of these, it's been 6 to 7 years now since these guidelines have been written, and they're definitely in need of some updating. But right now, that's the basis of what a lot of our current knowledge, at least guideline knowledge, is based on. So let's first talk about risk assessment, about how to assess that patient who's coming in for their surgical event. If we take all comers and without management, the incidence of adverse cardiac events related to non-cardiac surgery is pretty daunting. About 5.8% risk of major cardiac complications for patients over 40 undergoing major non-cardiac surgery, such as vascular surgery, or intra-abdominal surgery, intrathoracic surgery. In unselected patients, the risk of heart attack is about 1.4% and death of 1.1%. And then if the patient has risk factors, their incidence of death and or myocardial infarction goes up. There's a study done by Poldermans from 2008, just looking at high-risk patients and looking and doing perioperative testing of their operative course. And if you just drop troponin levels, a very high percentage of them will have a troponin leak, probably due to demand ischemia. A smaller number has a risk of myocardial infarction, and then a smaller number, but a significant number, at least in these high-risk patients, have a significant risk of cardiac death. So how do we ameliorate that risk, and how do we determine who is at higher risk for these events? So there are three elements to evaluating risk. So when you see a patient, you have to think about these three things. First is, what is the underlying diseases, patient-specific variables, what heart disease or other diseases that they may have that may add to adverse risk of undergoing surgery. What is their exercise capacity? Obviously, if the patient's more fit and can do more exercise, they probably can tolerate the stress of surgery, as opposed to a lot of the patients we see who have limited exercise capacity. And then what type of surgery are they having, because there are low-risk surgery, high-risk surgery, intermediate-risk surgery. So let's go through that. So some of the major predictors that require intense management and probably postponing surgery include if they are having active coronary disease, such as a recent MI, unstable angina, or severe angina. Obviously, if patients are going through elective surgery, they need to be postponed, evaluated, and treated. If they're in heart failure, especially class 4 heart failure or worsening symptoms, surgery needs to be stopped, as far as the planning of surgery, and they need to be managed to tune them up and get them prepared for surgery. And if they're having significant arrhythmias like high-grade AV block or significant VTAC or ventricular ectopies, SVTs, symptomatic bradycardia, all those types of arrhythmias need to be managed preoperatively before one can clear them for surgery. Other clinical variables that warrant careful assessment of current status include, just if they have underlying coronary disease, if they have cerebral vascular disease, if they have heart failure, diabetes, renal insufficiency, obesity, and obesity because it increases the risk of heart disease, pulmonary hypertension, sleep apnea, and DVT pulmonary embolism. So those are considerations. Minor predictors, but again, these have not really bear it out, is if the age group of the patient, the older the patient, the more at risk that they are. If they have some certain EKG abnormalities, these are really not significant risk factors, but if they have, let's say, a new left bundle branch block, they might be somebody that you might want to further evaluate, since they may have underlying coronary disease that's been undiagnosed. If they have atrial fibrillation, it becomes just, they can go ahead with surgery, but they become just a management problem. And if they have uncontrolled blood pressures. So, looking at, those are some patient-specific variables. If we look at the exercise capacity of the patient, we look at that the guidelines tell us that patients whose exercise capacity is low, and we use under 4 METs is sort of the guideline, that they may be at increased risk for an adverse event, and they should be, at least you have to go through a thorough process of how to evaluate them. So if we look at the what's considered 4 METs, it's actually doing light work around the house, like dusting or washing dishes. Usually I ask the patient, can you climb a flight of stairs? Can you walk about a half a mile? Can you, do a little bit more than the activities of daily living? That gets you above 4 METs, and that that means that their exercise capacity is satisfactory, that they usually can tolerate, surgery. If they're essentially bedridden or really limited as far as exercise, then there is a potential that they may be at increased risk. So then the third part of this is looking at the type of surgery that they're having, and we divide it between high risk and intermediate risk and low risk. And high risk surgery is aortic or other major vascular surgery, peripheral arterial surgery. Intermediate risk, and of course the one we do here is orthopedic surgery, is considered intermediate risk. But carotid endarterectomy, head and neck surgery, intraperitoneal or intrathoracic surgery, or prostate surgery. And then low risk are mostly ambulatory surgeries, endoscopic procedures, superficial procedures, cataracts, and breast surgery, and minor breast surgery like breast biopsies. So there are a number of risk models that we can use to determine risk, and I think it's something that should be an exercise that we should do for almost every patient. Maybe not formally, at least you should really think about this and really have, there are a number of risk indices that one could go through, and I'll just talk about the first 3. The last 3 are really modifications of at least one of the first 3. So we have the Goldman Risk Index, the revised cardiac risk index that we often use, and then there's an online American College of Surgeons National Quality Improvement Program. And we'll talk about those. So this is the Goldman Cardiac Risk Index, and this really was the first risk index, and it was published in 1977 by Goldman and colleagues. And what they do is they look at a number of variables like history, physical examination, electrocardiogram, general medical status, what type of operation, and assign points to each of these areas. And you can see if they've had a recent MI, that's okay, they get a lot of points for that. If they have signs of heart failure, a lot of points for that. And if it's an emergency surgery or intraperitoneal, intrathoracic, aortic surgery, they get extra points. And then they classify the risk as a class 1 risk if they have a low point, 0 to 5, and goes up to class 4, which is greater than 25 points. And one can determine and estimate their risk based on this. We don't really use this very much because this Goldman Risk Index has been modified and it's called the Revised Goldman Cardiac Risk Index, and we call it just the RCRI, Revised Cardiac Risk Index. And that's used very often. And what that uses is 6 independent predictors of major cardiac complications. So they just try to boil it down to 6. And this was published by Lee in 1999. So the 6 independent risk factors, if the type of surgery, again, if they're having high-risk surgery, that's a significant risk factor. If they've had a previous history of ischemic heart disease, and if they've had prior heart attack, or if they have active ischemia, or pathological EKGs, pathological QAs on EKG, they are considered higher risk. However, if they've been revascularized and they are no longer ischemic and they're doing fine, that would not be considered a risk. If they've had just a history of heart failure, is a risk. Cerebral vascular disease, like a TIA or stroke in the past, that's a risk. Diabetes, requiring treatment with insulin, that's considered risk. And preoperative creatinine greater than 2 is considered risk, so significant renal disease. And based on that information, the risk of cardiac death, non-fatal myocardial infarction, or cardiac arrest, if they have no risk factors, the risk is very low. It's about 0.4% according to their study. If they have 3 or more risk factors, the risk becomes very high. So that, again, it's a way to stratify risk and to help you advise the surgeon and the patient, as far as, what the risk of their surgery is upcoming. Do they really want to take a risk? This is in our case here with the orthopedic surgery, it's elective surgery. Now, if we look at the by the RCRI by different types of surgery, one can also predict risk. So if they're undergoing major abdominal surgery, like abdominal aortic aneurysm surgery, and looking at the different risk levels 1 through 4, you can see that the risk can vary between 4 to 12% with an RCRI risk index from 2 to 4. So let's move over to here to orthopedic surgery, and where the risk appears to be stepwise. So the risk of these major cardiac complications in somebody who would have an RCRI index of 4 or greater would be at about a 4% risk. So it is significant. So again, it's very helpful in determining what patients are at risk and advise again the surgeon and the patient what to expect as far as their outcomes from surgery. Now, we've looked at those factors, including the type of surgery, if it's high risk, if they've had prior heart disease, stroke, etc., diabetes. But what about aortic stenosis? That wasn't in the guidelines, RCRI. And the reason why they weren't in the guidelines is that there were so few patients with aortic stenosis, so that the original RCRI guidelines did not include aortic stenosis. There have been subsequent studies, and this one by Kurtai, published in 2004, looking at RCRI and aortic stenosis. And what they looked at were just patients with considered moderate to severe aortic stenosis with aortic valve area of less than or equal to 1, or a mean aortic valve gradient of greater than or equal to 25 millimeters mercury, and this is on echocardiography. And what they showed is that if the RCRI is 0, their risk still remains low. But as their RCRI, their risk index goes up, adding aortic stenosis significantly increases risk. And here, just an RCRI1 increases the risk factor by 10, and then from 2 or 3 or greater, it can increase the risk by 5-fold. So that having severe aortic stenosis alone does not necessarily increase risk if they have no other risk factors, but if once you add other risk factors, their risk of adverse cardiac events goes up significantly. Moving on to a different look at how do we can evaluate risk. There is a different method, and that's the surgical risk calculator. And this is the website that you can go on, and it's an active website. You just go on and plug in the numbers, and the numbers they're going to ask you is for age, ASA score, creatinine, functional status, and procedural type. So rather than going into the website, I thought I just copied these from the website, and I just took 4 examples of what the risk index would look like using this active calculator. And here's a patient who's age 60 years old, is having an abdominal procedure, that the ASA risk is 2, that the creatinine is low, less than 1.5, so it gives it a 0 score. A functional status, those are totally independent, so a 0 score. So somebody's very active, good kidney function. And the type of procedure, which is 9, which is the abdominal procedure, let's say gallbladder procedure. So that their risk of myocardial infarction and cardiac arrest is 0.12%, very, very low. Okay. So take a different patient, same procedure, 85-year-old with risk factors, and say their age, ASA class 3, their creatinine is high, greater than 1.5, their functional status is somewhat poor, and the type of procedure, and their risk goes up to 3.7%. So that's myocardial infarction and death, or cardiac arrest. And this is a 60-year-old patient who's has orthopedic surgery with liminal functional status in ASA class 2, normal creatinine, slightly limited functional status, but their risk is still low at 0.39%. But take an older patient that has multiple risk factors, again, ASA class 3, an elevated creatinine and poor functional status, and their risk is at 4.49% of significant cardiac adverse events. So this risk calculator is very valuable, again, for evaluating risk and to determine if, just to advise the patient and the surgeon of the potential risks. So when we are trying to determine risk and trying to evaluate patients, we have to get into what is their underlying disease and how do we manage them. So just want to talk a bit about different types of cardiac disease and the thought process that that may help in managing these patients. One of the first, when we look at coronary artery disease, we're thinking about, is a patient, able to undergo surgery, and what type of testing we have available to us to determine if they go, if they can withstand the rigors of surgery. In general, for the armamentum that we have exercise ECG, nuclear perfusion study, both exercise or pharmacological nuclear perfusion studies for patients who can't exercise, and we have stress echocardiogram and or dobutamine stress echocardiogram, which is a pharmacological stress test using dobutamine. And in general, we don't use exercise tolerance testing alone very often because it's not a very sensitive nor a very specific test. There's a lot of false negatives, meaning a patient could have coronary disease and you still end up with a negative test, or there'll be false positives because there are patients who have ST segment changes and not necessarily have underlying coronary artery disease, and that's why another modality is added to that, and that's where nuclear perfusion study and stress echocardiogram come in. Nuclear perfusion studies are very sensitive tests. If patients have a positive nuclear perfusion study, they have a very high likelihood of having a significant coronary disease. And but sometimes there can be some false positives with nuclear stress testing. Whereas a stress echo, you can sometimes miss patients with underlying coronary artery disease. But if you do get a positive test, they're very likely to have coronary artery disease. So are these two tests comparable? There has been a study done where patients had studies, both the dobutamine stress test and the pharmacological nuclear stress testing, done prior to non-cardiac surgery, and looked at outcomes. and the outcomes are no different, meaning that if the patient can go and tolerate a debuting stress test, that means that they probably can tolerate the stress of surgery. And so it is a worthwhile test. It doesn't require radiation, and it is a much easier test to do. It takes about an hour. It's easier for the patient. So, and it's a much less costly test. And so very often you'll see us ordering dobutamine stress tests here at this hospital. I think that's the most commonly ordered preoperative stress test. Now, this this preoperative screening with stress testing really change outcomes. And the bottom line is, if you take all comers, it really doesn't. And if you look at this study, and they looked at really the RCRI index essentially, and it's by Poldemans. And if you look at a year since screening after surgery, now this is following surgery, non-cardiac surgery, if you did no testing versus testing, their outcomes are essentially no different. However, if you get into those patients who had no risk factors, and probably the majority of these patients had no risk factors, versus if they had many risk factors, that's where it breaks out. If you have a lot of risk factors, then stress testing may add benefit. So that's how we determine if the patient needs stress testing. And again, this is another way to, another study looking at postoperative all-cause mortality in patients who did or did not undergo preoperative stress testing, matched by propensity score over 1 year after surgery, and you look at no stress testing versus stress testing, and the outcomes came out the same. So this is another way to look at, the association of preoperative stress testing with 1 year survival and subgroup analysis. And if you look at by the surgical procedure, there may be a benefit overall, especially with intra-abdominal surgery. Orthopedic surgery sort of, it really didn't show any major significant benefit. But where it breaks out, if they have a history of ischemic heart disease versus no ischemic heart disease, and obviously the RCRI index, if they have multiple risk factors, then stress testing is worthwhile. So that, let's say, patients go through stress testing. The question is, and they have a positive test result. Is there an advantage to have a patient go through coronary bypass surgery or a stent and delay their surgery, non-cardiac surgery, and then have the surgery afterwards? And this study looked at the preoperative prophylactic coronary revascularization. And what they found was really there's no benefit in outcomes as far as survival outcomes. There's very little benefit of a preoperative surgery. And so we're talking in large populations now. What I'm going to talk, what you also have to think about, there is a subset of all these populations where there may be benefit. So if you look at the CAD study, which is a very old study, coronary artery surgery study, and look at morbidity and mortality of sequential coronary bypass surgery and non-cardiac surgery versus no revascularization prior to surgery, that the mortality related to coronary bypass surgery was 1.4%, and the non-cardiac surgery dropped to 0.9% in total. So that comes out to about 2.3% mortality if you go through two surgeries sequentially. If you just go through the standard non-cardiac surgery without undergoing previous bypass or PCI, which is coronary intervention, then the outcomes are pretty much the same as far as survival. So it's pretty sobering. So where do we think that there's an advantage with having preoperative coronary intervention and postponing non-cardiac surgery? Well, if they have three-vessel disease, reduced left ventricular function, obviously if we pick up that they have left main disease, then there may be an advantage to bypass surgery in these patients to reduce the risk of perioperative infarct and death. Now, so we have patients who have coronary disease and they have risk factors and they're undergoing cardiac surgery, and the questions come up: what can we do to intensify their therapy preoperatively so that they would have a lower likelihood of adverse outcome related to their non-cardiac surgery? So if we go back to the RCRI, the Revised Goldman Risk Index, and down here and looking at beta blockers, does beta blocker add advantage to outcomes? And at least in the original data from Lee and Associates, that if we look at the rate of death, non-fatal infarct, cardiac arrest with VF, pulmonary edema, complete heart block, with the use of beta blockers, if they have no risk factors, their incidence still remains low. But if you start having one or two risk factors, the incidence of those events go from 2.2 to 6.6% to 0.8 to 1.6% with beta blockers. So it is significantly reduced. And if they have 3 or more risk factors, it can be reduced by 1/3. So beta blockers may have a role in preoperative management of patients with coronary artery disease. And this is another study looking at RCRI score and the use of beta blockers. Actually, beta blockers can cause harm. There have been documentations of adverse events and poor outcomes in patients who are at low risk. So if patients have an RCRI score of 0 or an RCRI score of 1, just one risk factor, there may be harm. The benefit really comes when the RCI score is high. So if somebody has, going through surgery, they don't have any symptoms of coronary disease, but you suspect that there may be underlying coronary disease, or if they have a significant number of risk factors based on the RCRI score, that beta blocker therapy should be considered. But definitely, if they don't have risk factors, it may cause harm, and it's recommended not to give it. Heart rate control related to surgery, and these are patients usually going through high-risk surgery, and this is a pretty interesting study looking at ischemia on 12-lead EKG and troponin levels related to surgery, and looking at preoperative and intraoperative heart rate control. If the heart rate is higher and patients undergoing at least high-risk surgery, they have more likely to have ischemia, and their troponin levels can be elevated. But with better heart rate control, you have less ischemia, less troponin leak. So the troponin leak is mostly related to demand ischemia. So these are this is a slide I used to go over the guidelines related to the use of beta blockers for patients undergoing non-cardiac surgery. And if we start here, if patients are already taking beta blocker, there's a class 1 evidence that they should stay on the beta blocker. Okay, so anybody who's going through any type of surgery should stay on the beta blocker. If they have coronary artery disease or risk factors, and if they're undergoing vascular surgery, there is indication that they should be on a beta blocker. And for intermediate surgery like orthopedic surgery that we see here, the level of evidence is there, but it's less robust. But still, they probably should be on a beta blocker, especially if they're having any ischemia-related evidence. And sometimes you can find we'll clear patients who have positive nuclear stress tests with a small area of ischemia in a certain area. They really should be on a beta blocker before going through surgery. There's no data on these areas of low-risk surgery. And if they have one or more risk factors, the level of evidence is lower. So it really becomes optional whether they should be on a beta blocker. And if they have no risk factors, they really should not be on the beta blocker. So again, I do think that based on the previous slide, if somebody's coming through, has maybe definitely 3 or more risk factors, they probably should be on a beta blocker, but less than 3, maybe, then it becomes a judgment call with the cardiologist and the patient. So that's looking at beta blockers. Well, does statins help in reducing risk of adverse cardiac event? And actually, the evidence shows that statins do help, especially in patients with coronary disease or at risk for coronary artery disease, like diabetic patients or high-risk patients. And this is a study looking at fluvastatin, less call, that was done a while back, and that there appears to be some improvement of risk in reducing risk in patients who are placed on statin therapy, and those patients that one would think that they're at risk for vascular disease. So statin therapy can be helpful when used preoperatively and continued through and postoperatively. Statins have two effects. It has a pleomorphic effect. One is obviously reducing the cholesterol level, but number 2 is that it does reduce inflammation within the coronary plaque. And that inflammation in the coronary plaque makes the plaque unstable and causes the plaque to rupture, especially under stress of surgery or the postoperative phase, and puts patients at increased risk of heart attack. So that by introducing a statin therapy, even shortly before surgery, can significantly reduce their risk intraoperatively and postoperatively of myocardial infarction or death. So this is just a summary of a number of studies looking at preoperative statin use, and all the studies are showing benefit, so that it is protective, so that there is definite benefit, and statin therapy should be considered in patients, especially with at risk for coronary disease or vascular disease. So, just looking further with coronary artery disease, and this is from the guidelines as far as how we should think about managing a patient as far as the screening and management of a patient with coronary artery disease. So, does a patient need emergency surgery in step 1? Well, if the answer is yes, you really don't have time to work up a patient so that they really need to go ahead with surgery. So what you need to do is you need to manage their risk right then and there. And if they have coronary disease and they're not on beta blocker, you might want to start a beta blocker. You might want to start a statin medication immediately and then have them go ahead with their surgery, but have to closely monitor in the perioperative phase. But if they do not need major surgery, if they have active cardiac conditions, and they, like we said earlier, if they have active heart failure, active angina, you really have to treat that first and get that under control before you proceed. And if it's low-risk surgery, really, if they're having some eye surgery, cataract surgery, they really don't need any workup at all, even if they have coronary disease, because it's such low-risk surgery, their risk is very, very low. But if they're intermittent or high-risk surgery, then one has to look at their functional status. Let's say they're not having symptoms, but if their functional status is less than 4 mets, they are very minimal ambulation, they can't climb a flight of stairs, they can't walk, 50 yards, and a lot of our patients can't do that. Then determination is, should they have further testing? If their exercise capacity is greater than 4 mets, the data shows that they usually can tolerate intermediate risk surgery very well. And then if they can't, then look at the number of risk factors that the patient has. If they have 3 or more risk factors, and if they're having vascular surgery, they really need, that's high-risk surgery, and they need to be worked up with cardiac testing. If they're having intermediate risk surgery, such as orthopedic surgery, then one has an option, and it's really up to it becomes a judgment call from the clinician and usually the cardiologist whether they need stress testing. So whether they do stress testing or go ahead with surgery with beta blocker therapy and a statin on board. If they have 1 or 2 risk factors and they're going through vascular surgery, again, it's the same thinking, either stress testing or maximum medical therapy. And if they have no risk factors, one can proceed with surgery as planned. Now, what about our patients who undergo PCI? That's a whole group of patients that we see that, and the question is when can we clear a patient who's undergoing stenting or angioplasty? So the guidelines were based on the evidence that patients who have had stents may be at risk for perioperative myocardial infarction due to in-stent thrombosis. And so that there have been specific guidelines drawn up to help us to try to determine what is the safest time to proceed with surgery. And it's related to the endothelial injury of the blood vessel where the procedure was performed. Just an angioplasty without a stent, the vessel heals pretty quickly. With a stent, that's a bare metal stent, the vessel heals over a short period of time. But if it's a drug-eluting stent, the idea of the drug elution is to prevent fibrosis within the stent, which really causes the in-stent stenosis, and that can really denude the endothelium for months. And it could take 6 months to a year for the endothelium to heal. So that's why these guidelines have been devised so that to allow the time for the endothelium to heal, so that proceeding with surgery is safe. So based on the guidelines right now, if we look at balloon angioplasty, actually you can operate after 14 days. So that if somebody needs surgery right away but they need an intervention, we'll often say go for balloon angioplasty. Why we don't recommend balloon angioplasty often is because the restenosis rate within 1 year is very high, like 30% or more. And that's also important to remember is that if somebody's had a balloon angioplasty 6 to 12 months ago, they have pretty high risk of restenosis, and they probably need to be restudied, at least by non-invasive testing, to make sure that they don't have restenosis. If it's a bare metal stent, we have to wait 30 to 45 days before their surgery, but after 30 to 45 days, most of the time we say 45 days, they can go ahead with elective non-cardiac surgery. And then the guidelines state that with a drug-eluting stent, you have to wait a year. And this can be problematic for some patients, and it becomes a real issue regarding, managing their medications, because these patients are on dual antiplatelet medications, aspirin plus, something like clopidogrel, post-PCI, and the recommendations that they should be cared for, should be avoided. Surgery should be avoided for a year. This is a study that Howard showed me, and I appreciate that, Howard, this is from the VA. And I thought this is a very interesting study because this is where the guidelines may need to be changed. And that the bottom line of this study, I know these graphs look a little confusing, but I'll go through it, is that it looks like at 6 months it would be safe to go ahead with surgery. And that the VA looked at their whole database, and I think there were about 40,000 patients who underwent PCI, non-cardiac surgery. And what they found was that by 6 months, 180 days, those patients who underwent drug-eluting stents, and I think the dashed line is the drug-eluting stent and the solid line is bare metal stents, that they're almost equivocal. So by 6 months, not 12 months, that the risk seems to be okay. And where it breaks out is if it's emergency surgery, the risk is very high. If they have a high RCRI index, the risk is very high. If they've had a cardiac event like an MI within the last 6 months, the PCI was done for an MI, those patients are probably at higher risk. So that there's probably a higher risk subset, but for the standard intervention, it looks like it'd be okay to go after 6 months. We have guidelines that say 1 year. This evidence that says 6 months, so that becomes a real conversation between the patient and the clinician about, risk and whether to go ahead or not to go ahead. This would suggest that patients could be taken off Plavix after the 6 months, but I think we just have to wait for finalizing if any revised guidelines to give us definite direction. So how do we manage these patients after PCI? If they're on, all patients remain on aspirin prior to and after surgery, unless they're undergoing spinal cranial surgery, and that's a special subgroup that you have to talk with the spine surgeon to determine if the aspirin can be continued, and most of the time it can't, but sometimes it can, and then if they're off aspirin, when it can be restarted. Usually the thienopyridines have to be stopped 7 days prior to OR or 10 days prior to spine surgery. In non-PCI patients, usually stop aspirin 7 days prior to surgery. There is a subset of high-risk group that I think the cardiologists identify that once in a while we'll want to keep a patient on aspirin even if they haven't had a stent. We might, if they've had coronary disease and they might have some ischemia on their nuclear test, we might say stay on the aspirin. I think we found out here, from our, ongoing surveillance here that the risk of bleeding postoperatively is not that much increased in patients remaining on just aspirin. Moving on to some disease-specific areas, mild hypertension, they're okay to go ahead, but if they have severe hypertension, they have to be managed and before they can go ahead with surgery. But avoid stopping beta blockers and clonidine because they can have rebound hypertension with doing that. But we always ask patients not to take an ACE or NO after the morning of surgery because of the increased risk of intraoperative and postoperative hypotension within the first 24 hours after surgery. Heart failure, again, I keep saying this, that if the patient's in active heart failure, you have to delay surgery. What about cardiomyopathy? Cardiomyopathy can be divided into systolic dysfunction, diastolic dysfunction, and hypertrophic. And I guess, if the patient's stable and well compensated, they're at increased risk, but as long as you're managing that and you're managed closely preoperatively and postoperatively, they can go ahead with surgery. And again, if they haven't had a recent echo, it's worthwhile to do that preoperatively. Valvular heart disease, there's a whole gamut of disease, but these are probably these valvular abnormalities, if they're significant, in other words, severe, would pose increased risk. In general, if they're asymptomatic, we can go ahead with surgery and have to be managed very closely. If they're symptomatic, then the valvular heart disease has to be intervened with, whether it's aortic stenosis with aortic valve replacement or just on down the line with other valvular heart surgery or interventions. So the next area I'd like to get into is just bridging, and this is under valvular heart disease, and how do we bridge for patients with prosthetic heart valves. The concept here is there is a group of patients who have prosthetic heart valves that are considered at low thromboembolic risk and then high thromboembolic risk. And actually the low thromboembolic risk valves are two types of valve. One is the tilting disc valve, like the St. Jude bileaflet valve, and the Medtronic called tilting disc, single disc valve. And these are considered low thromboembolic risk. This is a Sol's ball and cage valve, the Starr-Edgeworth valve, and that's a higher risk for thromboembolic disease. And so anybody has that type of valve, which is an old valve, that they would need to be bridged. If they have one of these bileaflet valve, a Medtronic heart valve, but other risk factors such as atrial fibrillation, previous thromboembolism, LV dysfunction, hypocoagulant conditions, or more than one prosthetic heart valve, they need to be bridged. Okay, or if they have any other type of heart valve or any valve in like the mitral position, they need to be bridged. So the bridging is, we have two options. one is it's considered a class 1 indication for warfarin therapy where they, for heparin therapy where they stop warfarin 4 days prior to surgery, and then you have to bring them in the hospital and start them on unfractionated heparin prior to their surgery, and then stop 4 hours before their surgery. This is really has been the gold standard by which we've been treating patients. However, because of the cost of hospitalization, there's been a trend now, and I think it's been well accepted that we can now use low molecular weight heparin, Lovenox, prior to surgery. So stopping warfarin 5 days prior to surgery, and then starting low molecular weight heparin, twice a day, beginning days 3 and 2, and then in the morning of day 1, as long as it's not spine surgery. If they're having spine surgery, they can't get any Lovenox the day prior to surgery because it increases their risk of operative site bleeding if they receive low molecular weight heparin the day prior to surgery. So just moving on to other disease areas, atrial fibrillation is more rate control or rhythm control, and then I'll talk a little bit about anticoagulation and that. SVTs and BT, they have to be managed. And then conduction abnormalities by themselves are not a problem, but if it's a new onset of a conduction abnormality, one might think that there may be something else underlying, and they may require further testing. So again, talking about anticoagulation bridging and about atrial fibrillation, we see a lot of patients who come through who are on warfarin therapy, who have atrial fibrillation. And how do we determine if a patient needs to be bridged? So we go back to the CHAD score and looking at heart failure, hypertension, age greater than 75, diabetes, and prior stroke or TIA, and determine their risk of thromboembolic event. So patients who have a low risk probably don't need to be bridged. So by low risk, that means that their CHAD score is less than or equal to 2, unless they've had a prior history of an embolism, then they're considered high risk. So if they had a stroke or a TIA and they're a 2, they're high risk. If they've had a prior, embolic episode to a leg or somewhere else, they're at high risk. So at low risk, we can stop the warfarin 4 to 5 days prior to surgery, make sure the INR is okay, and then restart the warfarin after surgery, and they do not need to be bridged. Now I put this up here because in Wisconowski, and this is a 2012 recommendation, but 2008 he published a study in Mayo Clinic Proceedings where they actually looked at CHAD score and the risk of bridging anticoagulation. He demonstrated in his study that that patients who are, what you're trying to weigh is the risk of bleeding with the bridging anticoagulation versus the risk of benefit, the benefit of giving the bridge. And what he showed that anybody with a CHAD score less than 4 actually had more bleeding and probably didn't help reduce the risk. I don't think that that's been really well received, and so the recommendation is that you should bridge for anybody above 2. But there's a bridge trial going on right now that's looking at this at intermediate risk patients to see if the benefits outweigh the risk. So here, this is the recommendations for high-risk patients, which include TIA, stroke, or peripheral embolism, or a higher CHAD score. And it's really the same bridging as we talked about for prosthetic valves. Now, this is an area that I found interest, in reviewing this is interesting. I don't purport to be an expert on this, but I'm going by what the package inserts tell us as far as bridging for prior to non-cardiac surgery. So we're looking at the new oral anticoagulants. So dabigatran or Pradaxa, here's the half-life. The recommendations, if they have normal renal function, they can stop it 1 to 2 days prior. If they have abnormal renal function, stop it 3 to 5 days prior. But on the other hand, rivaroxaban, which has a little bit shorter half-life, the insert states that you can stop it 1 or more days prior to surgical event. I tend to stop at 2 to 4 days. And then finally, the newest of the anticoagulants, apixaban or Eliquis, they recommend to stop at 24 hours prior to low-risk bleeding procedures. So if the surgical procedure itself is a low-risk bleeding procedure, you can narrow the window, and if it's greater than 48 hours, and then there's maybe a higher risk. In the original study related to Xarelto and in atrial fibrillation, there was what might be a rebound phenomenon by stopping the Xarelto and the higher risk of thromboembolic events. So that has to be kept in mind when you're stopping these medications. And there's some controversy about, was that a real effect, or was that just a poor protocol that they had in effect at the time of stopping Xarelto. So more to come on that. But these are what the package inserts state. But the one thing you have to be careful of is that following the post-operative dose, they're going to be immediately anticoagulated. So you have to wait. You know, you can't do this like warfarin where you can stop it the day after, you know, the night of surgery. You have to wait up to 3 days after surgery to restart the drug, or else they'll have potential of bleeding at their operative site. Just a few more things. Pacemakers, okay to proceed. We put a magnet over the device to turn off the sensing mechanism. ICDs, we have to turn off the device prior to and then turn on the device after procedure. Usually the device representative comes in and does that. I had the case where the device representative was not available and the patient could be like prone, so that they could put a magnet over the device, but you definitely need to interrogate, have the rep come in and interrogate the device to make sure it's working okay post-procedure. Severe pulmonary hypertension is something that we consider at this hospital a significant risk, because we're not set up to use intravenous nitric oxide to manage this intraoperatively. So anybody with severe pulmonary hypertension can't be operated on at this hospital. Congenital heart disease, it's just trying to manage their underlying heart disease. So lastly, I just, we do have guidelines at the hospital here regarding cardiac consultation. We do require cardiac consultation in a number of different areas. And then, but we do, even if a patient's had an outside cardiology consult, I just want to emphasize this. Some of these patients are very high risk and they have to be managed during their hospital phase, and I strongly recommend, and this is our guideline, that patients at high risk need to have a preoperative cardiology consult, because these patients are at significant risk. And I don't think any of the cardiologists in the room wants to find out that the patient with severe aortic stenosis and pulmonary edema in the middle of the night and they haven't been consulted on preoperatively. So strongly recommend that we follow these guidelines. So just the takeaways. We talked about the evaluation of cardiac risk, looking at patient-specific variables, exercise capacity, type of surgery. We looked at disease-specific approaches, type of disease, testing. Should we use beta blockers and statins, anticoagulation, bridging. We talked a little bit about the guidelines here at the hospital. So thank you.